with epilepsy. It's my pleasure to introduce Dr. Angela Peters. She joined the epilepsy division at the faculty at the University of Utah and the Salt Lake City VA in 2005. She currently holds a position as an assistant professor of neurology, is a diplomat of the American Academy of Neurology, and a fellow with the American Clinical Neurophysiology Society. She specializes both in epilepsy and neurophysiology. She currently sees patients at the University of Utah and Salt Lake City VA with medically intractable epilepsy who might be surgical candidates and specializes in neuromodulation. She's a member of the American Epilepsy Society, American Clinical Neurophysiology Society, and American Medical Association. She did her medical training at Baylor College of Medicine, a neurology residency and neurophysiology fellowship at the University of Utah. She also did an observership in surgical epilepsy at Cleveland Clinic and a pre-doctoral fellowship in retinal neurophysiology at the Retina Foundation of the Southwest. She has a research interest in post-traumatic epilepsy, neuromodulation, and a special interest in medical ethics and disability rights. Dr. Peters grew up in Saskatchewan, Canada, where her family resides, and met her husband, Everett Bacon, at college in Dallas, Texas. They live in Salt Lake City with their 3 dogs. Welcome, Dr. Peters.
Thank you. And welcome, everybody. It's so good to see people have such a commitment to learning about epilepsy and knowing what they can do to make their lives better, successful, and support people maybe in their life who have epilepsy. So I like to give this talk because I find in my clinic, a lot of folks really don't understand very much about seizures, epilepsy, and then the medications and the treatments that are there. And then I stole from my colleague, Jeff Bigelow, this little section on how to have a successful visit with your doctor. He gives a wonderful lecture about this, and he unfortunately couldn't do it this year, so I give credit to him on that. These are my disclosures. So first of all, we're going to go to basics. And a question that I often get is, what exactly is a seizure? What happens? What's happening in my brain when I have a seizure? And is a seizure, does that mean I have a diagnosis of epilepsy? A seizure is not necessarily a diagnosis of epilepsy. A seizure itself, the kind of the philosophical way of looking at it is that you have something in your brain that's causing an abnormal synchronous electrical discharge. It's abnormal neuronal activity. It's a surge of electrical activity, and that causes you to have symptoms. Kind of like a stroke is when you have decreased blood flow, and then that part of the brain doesn't work very well. A seizure is not related to blood flow, it's related to the electrical activity, and that overactivity causes that part of the brain to not function well, and then you have the symptoms of a seizure. There are a lot of things that look like epileptic seizures, but are not. To have an epileptic seizure, you have to have that abnormal electrical discharge. Some things like fainting spells, cardiac arrhythmias, abnormal heartbeats, migraines, acute stress responses, certain movement disorders like tremors. In some developmentally delayed kids, they have something called stereotypies, where they have like an abnormal behavior. Those aren't seizures. Sometimes they really, really can trip people up and fake people. And then that's when we have to do a bit of a workup to see what's really going on. So again, an epileptic seizure, you have an abnormal electrical discharge, usually synchronous, meaning if you looked at an EEG, it's all squiggly lines, and that's actually good. If you start seeing really rhythmic stuff on an EEG that's all together at the same time, that's actually not good. And I have it like a little there. That's like a seizure. What can really help us as doctors to determine whether something's an epileptic seizure or a seizure mimicker is videos brought in by the family. Then, of course, we do EEGs to look at those brain waves. We'll do imaging of your head to see if there's like something in there that might be irritable and cause your brain to have abnormal electrical discharges. And then we might do laboratory testing to see if there's something in your blood that could cause a seizure. We look at genes, and we look to see if you have maybe a bunch of other medical conditions that would be consistent with a syndrome that causes seizures. So that's seizures. What is epilepsy? A single seizure is not epilepsy, even if it's an epileptic seizure. If a single seizure is caused by something that is reversible, we call that a provoked seizure, and that does not give you a diagnosis of epilepsy. The way to think about epilepsy is you have a condition that will continue to cause you to have seizures. So you have an enduring predisposition. Your brain has an enduring predisposition to generate abnormal electrical activity that causes seizures. That's kind of the, again, philosophical definition of it. The practical definition is that you've had 2 epileptic seizures that are not caused by something that's reversible and separated in time, like more than 24 hours. If it's not caused by something reversible or a medical condition, then we would call those 2 unprovoked seizures, and that at that point we would give you a diagnosis of epilepsy. Sometimes we can give you a diagnosis of epilepsy with only 1 seizure if it's unprovoked, but your risk for a variety of reasons is really high. So who gets epilepsy? Epilepsy is a very common disorder, and it's very often a silent disability because it's not obvious to people around you. You might be surprised to know that 3.1% of the population has epilepsy. That's about 9 million in the US. 1 in 26 Americans will have had a seizure in their lifetime. That's about 5% of people. And 50% of those folks will go on to have epilepsy. The incidence peaks in children and older adults and is highest after age 75. And the most common cause is actually cerebral vascular disease. That's why older individuals tend to have a peak in the occurrence of seizures. Other things like Dr. Wilson talked about is genetics, certain birth defects or injuries that can happen. But about 70% of epilepsies, we do not know what causes it. And this is just a little graphic showing you that slice of the pie. There are certain things we can point to that will cause seizures and hence epilepsy. But this big slice here is what used to be called cryptogenic or idiopathic. Now we refer to it as presumed genetic. So Dr. Wilson was talking about why all that genetic testing is important, because we would like to understand this huge slice of the pie, these folks who have epilepsy. What are epilepsy risk factors? Intellectual disability or developmental disability tends to be a risk factor because your brain is often wired differently. You have a different kind of network, and that network might be prone to having abnormal electrical discharges. having a birth injury that causes cerebral palsy, basically anything that causes lesions in the brain is going to be a risk factor for epilepsy. Because when you have little lesions in the brain, either from a tumor or from old concussion, or even certain little malformations of brain tissue that people are often born with, they make your brain irritable electrically. They're like a little island of cells that disrupt the network and the normal flow of electrical activity. And when that happens, you're prone to have seizures. Other things that are risk factor is dementia, family history of epilepsy, because there's a lot of genetics involved, trauma, bleeding, birth injury. So I want folks to understand there are two types broadly of seizures. One is called focal onset, and the other is called generalized onset. And what focal onset means is that abnormal electrical activity starts in one part of the brain, and it might just stay there, or it might grow and spread to involve the whole brain. But a focal onset seizure is being generated in a particular area of the brain first. Generalized onset seizures, those are seizures that arise from abnormal electrical activity that just happens all at once in the whole brain. We think it's probably being generated in the middle of the brain called the thalamus. Knowing what kind of seizure you have is important because it can help us with treatment, prognosis, and also try and figure out why you're having them. Some examples of generalized seizures are absent seizures, staring spells, myoclonic seizures, the jerks that can either be single but then grow into a full convulsion, tonic seizures, that's when people get really stiff. Atonic is when they lose all tone, they fall. Clonic seizures are like the jerking in the body. And tonic-clonic is when you get stiff and then you have the jerking. Focal onset seizures, I'll show you a slide. They can be anything. There's lots of different ways those types of seizures present. So now that you know that, I just want you to understand that terminology has changed about how we describe seizures. A lot of folks use the term, well, I have these partials, this is my partial, this is my complex partial. And I always have to ask patients, describe to me exactly what you mean by that. We don't use the term partial or simple partial or complex partial anymore. Now it's more straightforward, actually. I just explained to you what focal seizures are. So partial is another word for focal. So what it just means, the seizure is localized to one part of the brain. So now we split it into focal. And if you have a seizure and you don't lose awareness, we call that focal aware. So for a lot of people having an aura where you feel something, but you're not losing awareness of your surroundings and can't communicate, that is a focal aware seizure. If you have a seizure that starts somewhere in the brain, but then it impairs your ability to be alert of your surroundings or communicate, that would be called a focal impaired aware seizure. Sometimes people have seizures that are only like psychic, like deja vu or odd feelings. We term those cognitive. And then sometimes, like I mentioned, those focal seizures might spread to the whole brain and what then become a generalized seizure. We use the term focal to bilateral tonic-clonic. Another term that most people are aware of is secondarily generalized. So like I mentioned, focal seizures can cause all kinds of weird symptoms. A lot of folks just feel or just believe that seizures are grand mal seizure. You fall to the ground, you have a convulsion. That is not true. I had one patient whose entire seizure consisted of her hearing spooky horror music. And she was completely alert and she understood everything around her. That's all it was. It was all in her head, spooky horror music. It was like she could feel it, not just hear it. That seizure actually happened to come from a particular region of the brain called the right parietal region. Thank you. Yeah. And I just put the slide up here, just, that you don't have to memorize this or anything. This slide, I show the residents too, but these are examples of all the different kinds of ways a person can act if they have a seizure from this particular part of the brain. The brain is specialized, there's certain areas of the brain that specialize in doing certain tasks. So when there's a surge of electrical activity there that causes a seizure, then you have like a very focal effect of how you're going to act. But the brain isn't, it's specialized, but it's also networked. So we understand seizures not in terms of just a small area, but its connections to other areas are related. And this is kind of the biggest field of research right now, is network connections, and how do we go about understanding them better? And then also in epilepsy, how do we modulate them so that we can stop that abnormal electrical activity? A generalized tonic-clonic seizure is either it can start off as a focal, or it can just, like I mentioned, if it's a generalized onset seizure, it will just go right into a generalized tonic-clonic seizure. So some things people will do is they might cry out, they might get a little blue, they might get stiff in their arms, sometimes like this, to put together. Eyes are usually open. Might be to one side or the other. Those are all clues that are helpful to me as an epileptologist. And then there's the clonic phase where they have the jerking. And then afterwards, there's the post-ictal phase. That's when people are confused and they're tired and they may need to sleep. They might be agitated. And if they are, you don't want to hold them. You don't want to confront them because they're confused. You just want to just be gentle, reassure them, try to reorient them. Some things that are important about someone who's having a generalized seizure, also known as a grand mal seizure, is to help them to the ground to prevent any injuries. That's one of the biggest things. We don't want people to have a head bleed. Turn them on their side, because they'll often have saliva, and we don't want them to aspirate on that. Do not put anything in their mouth. Time how long the convulsions are. Your doctor may give you a seizure action plan that tells you when to call EMS, when to use rescue medicine. And often it seems like that seizure is lasting way longer than it actually is. So actually timing it is good. Breathing can be heavy afterwards, but it should quickly return to normal. If it doesn't, then that's a cause for concern. You might want to call EMS. And then people often are very tired and sleepy, and you just want to let them sleep it off. If they don't wake up after 30 minutes or so, then that's a time you might want to call EMS. And it's all individualized. These are things, though, you should know in general, but discuss with your doctor. So now that we classified seizures, what they are, focal, semiology, coming from different parts of the brain, know that epilepsies as a disease or syndrome are also classified. And a lot of you are familiar with the old terms, so I'm going to kind of introduce you to the new terminology. When we think about epilepsies, we like to think of two things. The old way was to think of the etiology, or what caused it, and the other way to think about it is how did it present. So the old etiology, we might say idiopathic, which just means we don't know what caused it. Symptomatic is kind of a weird way to say it's caused by something in the brain. And cryptogenic is it's caused by something in the brain, like a lesion, but we don't know what it is. They're kind of counterintuitive forms. They were never really good. So that's why they changed the terminology. Now we like to think of them in terms of electroclinical, meaning that there are certain EEG patterns that result in certain ways of presenting, and then also etiology. So now we'll say you have a genetic epilepsy or a presumed genetic epilepsy rather than idiopathic. Instead of saying symptomatic epilepsy, we'll say you have a structural or a metabolic epilepsy syndrome. If it's cryptogenic, we just make it clear that it's unknown. You have an unknown type of epilepsy. And then there are other categories. There are certain infectious and immune syndromes that can cause seizures and epilepsy. So now that you know all that about seizures and epilepsy, and you've had it, your first one, you may be seeing a neurologist, or maybe you have a more complex epilepsy and you're seeing an epileptologist for the first time. These are the things during your visit that we're thinking of, that we're trying to get information from you to answer these questions. First thing we want to know is, was your seizure epileptic or not? Was it one of those seizure mimickers I mentioned? Was it provoked? Was it caused by something reversible? And then I want to know, what kind of seizure was it? Was it a focal one, or was it a generalized one, like we talked about? And then I'm going to think about etiology, and I'm going to try and see if there's any evidence for an underlying neurologic condition that could be causing you to have seizures. And then I'm thinking of what are the best studies I need to do to figure this out. And then there's the question, do we start a seizure medication? What do we do with that? And if we do, which drugs should we use? So it is very helpful to help your neurologist answer these questions if you do a little bit of preparation. So it's helpful to have somebody with you who can describe what happens when you have a seizure. And I tell you, videos are priceless. Videos can tell me so much. Find out about your family history. Ask around, like, do you have cousins? Is there anybody in your family who has seizures or epilepsy? Also find out, did you ever have staring spells as a kid? Did you ever have seizures with a really high fever? That's something we call febrile seizures. There's sometimes that can lead to an increased risk of seizures down the road. Ask your parents, did I ever have like a bad concussion or a brain infection like meningitis? And then know your past medical history. And don't get snarky with us if we're asking you about it, because we want to hear it firsthand. Not everything we see in the chart is accurate. It's very often not accurate. Or we need clarification on something. We're going to ask you things that you've probably already said to multiple doctors. We really need any past testing. Usually, like at the U, that stuff's all going to be collected by our schedulers beforehand. It's very helpful to have prior imaging on CDs, know what medications you're taking and the doses and why. And if you stopped a seizure medication, write down, try to just jot it down and write down, why did you stop it and how long were you on it? When we ask you about illicit use, please be honest. Tell us about any drug or alcohol history or prior overdoses, because this can all help us try and figure out why you're having seizures. Keep a seizure diary, note triggers, things that tend to bring on seizures. And for women, also note your menstrual cycle, because that can really help us determine if you have a type of epilepsy called catamenial epilepsy. And then, we don't have a lot of time in clinics. So write down your questions. Think about what you want to get out of your visit. Write it down and don't be afraid to ask. That's okay. You can bring, I have in my clinic, I have patients, they have a piece of paper, sometimes 10, and they have all of their questions there. And I don't mind answering them. We're specialists, we're subspecialists actually. And this is our job. The things that we are probably going to do to figure out what's going on is an EEG. That's where we put all the little stickers on your head, and we're going to record your brain waves. A routine one is about an hour, sometimes 2. We're going to want an MRI, which is a high resolution scan of your brain. We can also get a CT head, but it doesn't give us the detail that we need to look for some sort of lesion that could be causing seizures. We'll get blood work, or usually it's already been done by the time you reach a specialist, but we might order some more special tests. Sometimes we might do a spinal tap. And that's if we want to look at particular causes for you to have epilepsy. And then the question is, do we start a seizure medication or not? In general, we do not start a seizure medication until after your second unprovoked seizure. And the reason why is because it's about 40% chance recurrence after the first one. After 2, it's about 73. We can bring that recurrence rate down by 30 to 60% by starting a seizure medication after your first seizure, but the risk benefit is not always there. There's a caveat to this. There are some situations where you have a high risk of recurrence, even if you've only had one unprovoked seizure. So those are the calculations we make in clinic, and then we'll discuss with you whether to start a seizure medication. And then when we do, the things we consider is what kind of seizure did you have? What kind of epilepsy do you have? Because some medications work better. What is the cost? And then we look at pharmacokinetics, like how quickly the drug gets into your bloodstream and how long it stays that way. We try to use medications that will help you to be compliant with taking them, because it's not fun to have to take 2 pills every day for the rest of your life. And then we look at related medical conditions, because that makes an effect on what drugs we pick. And Carrie showed you this. It's just important to see that there's been a huge boom in medications, and they're all really good. It's not just new medications. It's actually some reformulations of older ones, so making them long acting, so they're only once a day. So the older medications were effective for seizure control, but they're dirty drugs and they have a lot of side effects. And just so you know, we do not use phenobarbital or phenytoin, that's Xylantin, in outpatients anymore. So if you're still taking that medicine, we need to get you on a better one. And then there are rescue medications. Dr. Wilson talked about the nasal sprays. There is one in study right now, which is got some drug dynamics that look really, really good, make it really effective. And you could give it to somebody in the middle of a grand mal seizure. They just need to be breathing. And that is staccato alprazolam. That's in phase 3 study right now. We are doing that study over at the University of Utah. And I think there's some information about it outside too. And then when we start medications, about 47% of patients will be seizure-free after the first medication. Seizure-free in this, I'll talk about that in a little bit, doesn't necessarily mean you never have another seizure for the rest of your life. After we add the second one, only about 13% will be seizure-free. And once we add the third, only about 1%. So it turns out that about 1 in 3 persons with epilepsy will have drug-resistant epilepsy. Drug-resistant epilepsy means you have failed to be seizure-free on 2 medications that you've taken at a therapeutic dose and for a therapeutic length of time. We would also say you have drug-resistant epilepsy if you do have a decrease in seizures, but they're affecting your quality of life, or they put you at risk for something called SUDEP, and I'll talk a little bit about that later. In these drug studies, just know seizure freedom was defined as no seizures in the last 12 months or 3 times the longest pre-treatment interseizure interval. So it doesn't, there's a little bit of a misnomer to say seizure free. It just means there is a pretty good reduction in seizures. You can still have breakthroughs. Why do we want to treat? It's very important. People can die with epilepsy. They can die from, drowning, status epilepticus, from seizures that don't stop on their own. And then there's this thing called sudden unexplained death in epilepsy, which we don't understand very well. The numbers vary. It's about 1 in 10,000 of newly diagnosed patients, and maybe around 8 to 9 out of 1,000 drug-resistant epilepsy patients. The risk tends to be higher in kids that are syndromic, in males, and usually within the first year of being diagnosed. But we have to treat your seizures because they're not good for your brain and they can be dangerous. Also, they can affect your quality of life to the point where there's pretty high suicide risk. I'm just going to briefly mention CBD oil because it's one of the most popular questions I get in clinic. There have been trials that shows that CBD oil, a highly purified form of it, is effective in certain types of epilepsies. This is called Epidiolex. There's no evidence to support it as the only treatment for epilepsy. It has to be used together with another anti-seizure medication. And the kind of CBD oil you get like in a store that's not prescribed, we really don't have a lot of data about that. So it may help people anecdotally. I have patients who say it made their seizures worse. Medical marijuana, despite all the hype about it in epilepsy, there really have not been good tests. There haven't been rigorous investigations. And when there have been, they tend to show that medical marijuana does not help. But there's not very good rigorous data for it. So we have limited data, and the American Epilepsy Society would like to study this more. So we support rescheduling it so that we can have more data about this. And then other things that treat your epilepsy are really important. Lifestyle modifications, adequate sleep, avoiding alcohol, you can drink, you just can't binge drink, and you don't want to drink too much where you go into withdrawal. You want to avoid a lot of medications that are stimulants, although there is evidence to show that if you have ADHD and you need to take a medicine, that has been shown to be safe in most cases. So these are questions that you can always ask your epileptologist. Stress reduction is so important. Stress is a big trigger for people with epilepsy. Mindfulness, meditation, biofeedback, music, and art have all been shown to help reduce seizure frequency. So now that you know that, when is it time for you to see, not a neurologist, but an epileptologist? So I'm an epileptologist. That means I'm a neurologist in my training, but then I did additional training in epilepsy and epilepsy surgery and these complex kind of epilepsies. We can do a lot to treat complicated epilepsies. So the time to see an epileptologist is if you failed medications, so you're in that drug-resistant category. If you have focal seizures, it probably needs a workup because it might be something we can cure. If you need to get off an old medication, like I was showing you, phenobarbital and Dilantin, That's probably something you might want to see one of us for. If you're taking seizure medications, and especially if you're taking several seizure medications and you want to get pregnant, we have specialized training to help you get through that. So what we do is we determine whether your seizures are epileptic or not, what kind of epilepsy syndrome it is. We develop treatment plans. We manage complex medication syndromes. We do the workups for epilepsy surgery and for the brain pacemakers. And then we do all the programming for it. And then we treat complicated pregnancies across all ages and also in pregnant women. I just want to say something briefly about women who plan to get pregnant. Over 90% have normal, healthy outcomes. You need additional folic acid in addition to what's in your prenatal vitamin. You should be on particulars anti-seizure medications because there are 3 that are known to be very safe in pregnancy. And if you need to switch to those, that's something we can help you with. You don't want to be on, I showed you that chart of the first generation anti-seizure medications, the second, not now all the new ones. You don't want to be in that first generation seizure medications if you're planning to get pregnant. And we want to prevent seizures during pregnancy because that is where the real risk is. So what kind of special tests do? We do something called a video EEG study. This is kind of the gold standard to figure out if your seizures are epileptic or not, and then where in the brain they're coming from broadly. What this is you come in electively to a unit. We put all those electrodes on your head. We take away your seizure medication, we sleep deprive you, and then we wait for you to have a seizure so that we can capture it on video and EEG. It sounds like, well, that's fine. I'll just stay in there in the room and watch TV. You'll start to hit the wall after about the 2nd or 3rd day. For those of you who've had this, you know what I'm talking about because you're just in that room, off your medicine, sleep deprived. It's very boring and a bit stressful, but at the same time, that helps us bring on seizures too. Like I said, it's our gold standard. We need to rely on this study. We can sometimes do one where you can take home, that's called an ambulatory EEG. We can do genetic testing, autoimmune testing, and then we do specialized brain imaging. I'm not going to go into this too much. Dr. Wilson did. Just know that there are different gene panels that we could do. Nowadays, we like to go right to whole exome sequencing. That way we get all the information we need. We don't have to do one and then do the next step and do the next step. So this is your pathway through epilepsy care. When you're first diagnosed, you're probably going to get imaging. You're going to get a workup to see if your seizure was provoked, not unprovoked. Do you have a diagnosis of epilepsy? You'll be referred to a general neurologist who will put you on medications and see if they work. If they're not working, hopefully you're going to get referred up the line to an epileptologist. And that's when we'll consider more advanced treatments like brain pacemakers that we have, surgeries, or multiple medications that are combined in the most effective way with the least amount of side effects. That's something called rational polypharmacy. And then we have all kinds of study medications. So these are wonderful new therapies out there that are being tested that you might be a candidate for. Even things like stem cell therapy. We have a study at the U where we're looking at that for a particular kind of epilepsy. So now let's talk just a little bit about epilepsy surgery. You are a candidate for epilepsy surgery if you have failed medication, you continue to have seizures, they're disabling, so they're affecting your quality of life. You're especially a candidate if we can relate all those seizures to a lesion in your brain that we can take out, make you seizure-free. You need to be motivated. We need to know that you're going to comply with the whole workup because it is a workup. And we have to know if we do this, you should have a high probability of being significantly better. Far fewer seizures, better quality of life. Our goal of seizure surgery and neuromodulation is seizure freedom, or at least a significant reduction. We want to improve your quality of life, and we want to decrease the number of medications. But I want people to know it doesn't mean that we're going to be able to get you off your medications. It does happen rarely, but that is not the norm. Usually we can simplify them though. So this is just a flow chart of what happens. If you're a candidate for epilepsy surgery, you go into what's called stage 1 workup. You go into the surgical pipeline. So you get diagnosed with intractable epilepsy. You're a candidate for reasons we've determined, and you agree that you want to go on with this workup. So the first things we'll do is that video EEG, MRI, we'll do some special head imaging, we'll do neuropsychological testing, which is actually a way to do brain mapping. Then we might go and do some other things based on your clinical situation. And then we conference you. We present your case to the conference where the neurosurgeons are, all the epileptologists, neuroradiologists, neuropsychologists, a bunch of people. And then we determine, do we have enough information to say, oh, we can do this resective surgery or go directly to a brain pacemaker? Or do we need to hone in on where the seizures are coming from more in order to figure out exactly where to do surgery or exactly where to put that brain pacemaker? If we do decide that we need more information, then you go into what's called phase 2. Phase 2 is what Dr. Wilson was showing you, where they put those stereo EEG depths into the brain. They're like angel hair spaghetti. You are under anesthesia. There's a robot guided by a neurosurgeon. The robot's not doing it all themselves. And they did tiny little burr hole, and then they put these electrodes into the targeted region. So I've determined where my target is, where the network is involved. And I'll tell the surgeon, this is where I want it. And then he puts them in there. And then we basically do the video EEG study all over again. And this time though, we're getting like high resolution data because we got the electrodes right in your brain, and it gets very, very precise. And then after that, then we can go to you and say, okay, we know exactly where the seizures are coming from. We can do this surgery right here. Here's your chance of being seizure free, or what we expect your reduction in seizures will be. Sometimes if you are not a candidate for resection, then we'll say, well, we can put a brain pacemaker in there to stop the seizures. And I want to tell you why, it sounds scary, brain surgery, but we've been doing this since the 50s. It's actually a very streamlined, standardized way to approach this, and it's very effective. There are some epilepsies where we have up to an 80% chance of cure. And by cure, the definition for cure here is a little different than the one for those drug studies. Cure means you may have some auras, and that's it. Like no more seizures. In general, with anterior temporal resection, your temporal lobes are on the side here, 66% chance of cure. If we do resection somewhere else in your brain, a little bit lower, but still around 50%. Everybody gets at least improved. Very, very rare are they not improved. These numbers here too, they're a little bit old. It's actually less than that. Now, if we can't do resection, there is something called a brain pacemaker. This is called NeuroPace. There's actually two kinds. NeuroPace is this little device. It gets permanently implanted in your skull in a titanium tray, and we have two electrodes that we can plug into it, and those electrodes go right into the area where the seizures are coming from. This little device is constantly recording your EEG, and when it senses a seizure, it sends a little stimulus, and that stops the seizure. It is very effective. We can use it where in certain cases where we can't do surgery. So in the past, we would have said, well, we have to just manage you with medicine, that we can't do any surgery. Well, now we can use NeuroPace. This is especially true if like seizures are coming from both sides of the brain, or they're coming from a part of the brain that we can't take out because that would cause symptoms, undesirable symptoms like paralysis. Or for a lot of patients, they're like, well, I just don't like the idea of resection of my brain. I can't deal with that. I know maybe that's the best chance. Well, we can do NeuroPace. There's almost no case where we can't do NeuroPace. Outcomes are really good. 3 out of 4 people will have greater than 50% seizure reduction. 1 in 3 patients will have a greater than 90% seizure reduction. 28%, so almost a third, will have a seizure-free period of greater than 6 months. And these are folks who have been having seizures, multiple times a week. And the overall seizure reduction is 75% at 9 years. And the data is showing the longer you have it, the better it works, because it's actually retraining the networks in your brain to not have seizures. And it's not just that. We see a reduced rate of SUDEP, and we see benefits to your memory. The other kind of pacemaker is called DBS. DBS stimulates differently. It's a different kind of device. It goes into the thalamus. So it goes into a part of the brain that has a lot of connections to the limbic region of your brain, where a lot of seizures spread. This device will be on for a little bit and then off, kind of like VNS. So it cycles. So it's constantly cycling. The newer models can detect some changes that may indicate it picked up a seizure. So, but I can't read the EEG. I can't hold the EEG up on the screen like I can with NeuroPace. There's about a 40% reduction in seizure frequency and around 70% over time. And most people are good responders to deep brain stimulation. Vagal nerve stimulator, a lot of you are familiar with this, been around since the 90s. It is a little electrode that wraps around your vagus nerve, which is the longest cranial nerve is in your neck. The vagal nerve stimulator cycles, so it's on for a period of time, then it's off for a period of time. About 35% of patients have about a 50% reduction in seizures. So about 1/3 of patients will have a really good response. Overall, it's maybe about a 30% reduction in seizures. It can improve mood, and it often will help augment our use of seizure medications and allow us to peel back some seizure medications. And then just so you know, we don't always have to open up your cranium to do resective surgeries. We can do something called laser ablation, which is just what this shows. No big craniotomy. The surgeon has a little cannula and then can use a laser to ablate the area that we would have otherwise wanted to resect. You go home the next day. It's very non-invasive. So now that you know how great these advanced therapies are, how long do you think it takes before being diagnosed with drug-resistant epilepsy and getting referred to somebody like me? Any guesses? 20 years. Yeah, 20 years. Yeah, this is why I'm here, trying to tell everybody that there are great and awesome treatments out there. And we can do stuff. And it's in the last 10 years, with NeuroPace and neuromodulation, is revolutionized the treatment of epilepsy. We can do a lot. But it means that often you need to be referred to a comprehensive epilepsy center. What this is a level 4 center where there are epileptologists, functional neurosurgeons. Functional neurosurgeons are neurosurgeons who have specialized in doing epilepsy surgery. We have our own neuropsychologist. We have epilepsy nurse coordinators, neuroradiologists. So that's what level 4 center is. Also, if you're referred to an academic center, you have access to all the studies that we have going on. So we have a lot of drug and device studies going on right now. And you may be a candidate, and these are exciting, and this is also the future of treatment as well. So that is an advantage. So I just want to point out, Epilepsy Foundation is a great resource, epilepsy.com. There's everything in there about epilepsy surgery, along with everything else about epilepsy. Neuropace.com is a great site to look at for neuromodulation, those brain pacemakers. And then you can also go to our website at the university just to find out about our epilepsy group. We have 6 epileptologists. We're expanding. We're overworked, but we are bringing in patients, and we love to have you. Don't wait 20 years. All right. We'll have questions at the end of this. So I think, Jessica, we're going to go to break. Okay.
Yeah, thank you. Thank you, Angela. That was so helpful. All right, it's 11 o'clock. We're going to take a 15-minute break. So go visit our vendors. The restrooms are out to the corner there. We still have some coffee and some water in the back, and we will be back at 11:15.